Parents in search of a diagnosis or the best rehab treatment for their kids' individual needs, you won't want to miss this episode. Thanks for joining me today. Welcome back to Live Action Fitness with me, Coach Jason. I'm joined by friend of the program, Dr. Kelly Pham from Reach Pediatric Therapy. Thanks for being here.
Yeah, thank you so much for having me, Jason. I really appreciate it.
Absolutely. So we know you do rehab treatment and diagnosis. So not many people know about your specialty, but they really need to because they have a need. But I want to dig into what you do when we're just getting started. So if there are parents out there, maybe they need a diagnosis, but they don't know how to go about it, or they're facing a zillion wait lists. How do we get started? What's the first step if I'm one of those parents?
Yeah, absolutely. Great question. So I think the first step is really understanding where you need to be. And I think a lot of parents don't know. And I think that stems from maybe a lot of pediatricians not really being sure what type of provider a child needs to see in terms of taking that first step towards a diagnosis. So, I am a pediatric physiatrist or a pediatric rehabilitation medicine doctor. So, we actually don't provide any sort of physical therapy or active rehabilitation in our office currently. It's myself and a developmental psychologist, Dr. Sharon Stink, and we work with slightly different patient populations. So I work with a lot of young children who present with physical disabilities. So, difficulties achieving their gross motor milestones, fine motor milestones, maybe even sometimes communication, or what we would call global developmental delay, meaning that there are two areas that a child is delayed in. Sometimes we see kids who have abnormal muscle tone, whether that be high muscle tone or low muscle tone. And I'm evaluating those children to help figure out why and to help guide their rehabilitation plan so that they can get the therapies that they need, any bracing or equipment that they might need to make progress to be as independent and successful as possible in terms of generally their mobility. Dr.
Mm.
Singh, on the other side of things, as a developmental psychologist, she looks at the global development, but really focuses on the side of communication and social development. And so she does a test called the ADOS, which is a test that is used to diagnose autism. She also often does not give a diagnosis of autism but evaluates children for that diagnosis if there are concerns about social participation, about behavior. That can be another big one. She also does some parenting work, especially around behavior and children who are neurodiverse. So we work in this complementary way, but on slightly different areas of development and participation for young children in their environment. Now, Dr. Singh works with about 0 to 6 year olds. I work with the entire lifespan. So I work with babies in the NICU all the way to your 70-year-old grandma who had a stroke because I am both an adult and pediatric rehabilitation doctor. And so, one of the great things that allows is for me to work with children as they go through adolescence and into young adulthood. Whereas typically kids would graduate from their pediatric provider and move on to an adult provider who maybe doesn't have quite the same understanding of their childhood disorder. There, as you mentioned, Jason, there are lots and lots of wait lists out there. Our practice is a little bit different. Dr. Singh is out of network with insurance companies. Her next available appointment, I believe, is next week. My practice is primarily a concierge practice. So we do take insurance, but there's a membership fee that includes what we call non covered services. We do have two multidisciplinary clinics that are purely insurance based. One of those is toe walking, which I think we'll talk about. And the other is our infant toddler motor development clinic, where we evaluate 0 to 5-year-olds who have concerns about motor development in particular.
Interesting. There's so much there. So with these developmental milestones, because I'm picturing myself like as a parent, so if I had kids, I may not know all the details. Obviously, that's why we need you to come in there as the expert and to give the proper assessment. So what would it look like if I had a kid? What might I be seeing where I'd say, wow, maybe I should make an appointment with Dr. Pham or Dr. Singh because they're maybe not hitting these milestones? Does this have to do with rolling over and crawling and walking and things like that?
Right. Yeah. So, from a motor standpoint, we look at a couple different things, and the CDC made some changes to the developmental milestones within the last 5 years. These changes were quite controversial in the therapy world. And so I would say that many pediatricians will follow the new CDC recommendations. Some of them maybe don't know about the new CDC recommendations and so may follow the old recommendations. But in general, we're looking to see, is a child meeting their milestones and not in a way that is super delayed? Now, what does that mean, right? We think of a child as walking by about 12 months. Not every child walks at 12 months, right? My child walked at 15 months, and that was totally okay, right? And so there's some variability. Some children walk early, some children walk late. It's a bell curve of
Right.
things that are normal, and there is a lot that is normal and some that is not. And so if there's a big sort of discrepancy in when a child should be meeting a milestone and when they are, that would be concerning. The other thing is that if a child is stuck at one level or at one developmental skill and not making progress, for example, my child has been able to crawl for 6 months and they have not yet started to pull to stand. They're not walking, they're not bearing weight through their feet. Things like that are concerning, not making progress as we would expect from one milestone to the next. On the other side of things, in terms of the population that Dr. Singh works with, we might see some really just differences in communication and in social participation in terms of meeting those milestones. And if we're seeing something that looks different, if we're seeing behaviors that might be consistent with something like a diagnosis of autism, we look at the big picture, right? So it's not just you have not met these specific milestones and that's a problem. It's more of a big picture, like this is how you're interacting in the school setting, in the home setting, in the office setting. What does a child look like in all these different areas? And what do they look like with different people? Because especially when children are in that like 2 to 5-year-old range, they're incredibly challenging to work with. And
You
anyone
don't say.
yeah, anyone who's had a toddler or little person can appreciate that just challenging age group, and it's even more challenging to assess them for specific diagnoses, especially autism. There are some cases where it is very clear cut, where even I might say, wow, I really think this kid has autism, but there are lots of cases where it's more subtle. And I really like Dr. Singh's approach of really not over-diagnosing and making sure to look at the child in different settings because they oftentimes look very different and participate in a different way in different settings with different people.
Yeah, that's such a great point. Different settings, different locations, different people, and that might you might see different behavior from
Yes.
the kid.
Yes.
Exactly. So she'd be a great person to see, Dr. Singh, with that global perspective. I think that is so important. So she's looking more with the communication skills, language skills, eye contact, these social skills. Now, I think more so with you, maybe you mentioned movement and the gross motor milestones and muscle, right? It's where our movement comes from. So just briefly, how often is it an issue where there's like general like lack of muscular strength, even for these kids where maybe it's presenting as a problem where they're losing balance, they're not so coordinated, they're having trouble. You're going to see it when they're playing sports or running around on the playground. How often is it that it's a problem where there's not enough muscular, like physical strength, especially in the core, or maybe some muscle tightness? Because we usually think of kids like, wow, they're like super flexible, like they're going to be like a 12-year-old gymnastics girl in the Olympics and like they're Gumby. But I see a fair number of kids, and I've been surprised where I'm like, wow, like seem actually really stiff. Sometimes some muscles are really stiff. Some of the muscles, they're not strong enough.
Yeah. It really depends on the child. I don't know that I can give you a specific number about how many children have X, Y, or Z, but when it comes to any sort of delay in motor milestones, we have to take a step back and think about why. Is it a matter of a lack of strength? Is it a difference in muscle tone? And so those two things are different. And sometimes we think about them in the same way. But I see a lot of kids in the 0 to 5 range who are hypotonic, meaning low muscle tone, meaning when you grab their arm and move it like this, you feel less resistance to passive movement. And so low muscle tone can impact your ability to use your body. A lack of strength can impact your ability to use your body. And abnormal movements, whether that be movement disorder or sort of an increase in muscle tone on the flip side of that, can result in stiffness and difficulty utilizing the body. The last piece is something called motor control, which is your brain's ability to tell which muscles when to move and in what sequence. And motor control often physically looks like coordination. And so, even if you have the strength, can you put together the movements in succession to do a specific action? And so, all of those things combined can affect a child's motor abilities.
That is fascinating. I was just about to ask about the neuromuscular connection there. So you're saying there's a difference between the motor or muscle tone, the
Mhm.
physical strength, and the neuromuscular control.
Yes.
Fascinating, right? These are three different things. And I want to get into our next topic here, and I think it will relate, I believe. Sometimes I wonder and think about how, let's say, handwriting. It's a fine motor skill, and all the kids we're typing more nowadays, but you got to learn how to use a pen or a pencil or a paintbrush or whatever kind of utensil you're using. You need to get a grip on it. And handwriting, I don't have great handwriting, but it's even worse when I use my opposite hand, right? We have one hand that has a better control than the other. So
Right.
is it just a matter of practice and developing this fine motor control?
So, practice is certainly part of it. With regards to hand dominance, that just speaks to certain areas in our brain
Mhm.
and their dominance from a motor standpoint. And people who are right-handed tend to be left brain, quote unquote, dominant. And oftentimes people who are left-handed are actually still left brain dominant, but some of them are flipped. And so that impacts some of the other functions of our brain that we think of as being on one side or the other. Now, the different sides of the brain talk to one another. They send signals from side to side, but there is that dominance in terms of motor function and motor planning that we see most predominantly with the hands, but we also see it in the lower body as well. And what happens is once you start using a specific side more, you continue to utilize the same patterns repeatedly, and then your brain learns the same patterns repeatedly. So If I continue to write with my right hand, I write with my right hand. That's all I ever do is write with my right hand. I have kind of set my brain up to learn that single pattern. People who have had a stroke or an injury to one side of their brain may be forced to use their non dominant side.
Mhm.
Depending on their age, that may be easier or more difficult. If your brain has learned for 50 years, I write with my right hand, I write with my right hand, I write with my right hand, it's really hard to retrain that.
Yeah.
If a baby who was meant to be right hand dominant has a stroke in utero, guess what? Baby's going to be left hand dominant and they're going to do fine because they will start at a very young age using that left hand and it will repeat in the brain left hand for handwriting, left hand for handwriting, left hand for handwriting.
Yeah.
And that pattern that your brain learns. I meet a fair number of children whose parents will say they are forced to be left hand dominant because they had a perinatal stroke, but I think they really were meant to be right hand dominant.
Hmm.
So that happens not infrequently. But a
Interesting.
lot of it is what you do to create those motor patterns. And that is what we call neuroplasticity. It's the brain's ability to evolve and change the functions and to sprout new neurons that do different things.
Yeah, absolutely. That's a whole nother big topic, which
Yeah.
I can't believe we didn't think about the brain as being plastic and neuroplasticity, like not even all that long ago.
Yeah.
But yeah, so incredibly important. And then, like you're getting at, the training, which comes from the repetition, is where this pathway comes from,
Yes,
right?
exactly. And toe walking is a perfect example of that. I know that's something you wanted to about, and this is a perfect segue
Yeah.
because there are lots of reasons why kids walk on their toes. What happens over the course of time, no matter what the cause is, the brain learns toe, this is how I walk, this is my pattern of walking. I've been walking like this for 5 years, 7 years. And that is what the brain learns. That is what the brain knows. And so it's more challenging the longer you wait sometimes to retrain that pattern because the brain has learned it.
Yeah, exactly. So, for people who are new to this, if you could just tell the audience a little bit more about like toe walking, like what it is, what it looks like. You can observe it generally. It's noticeable sometimes, but I see a lot of the kids doing this. And even before I started my own fitness program, when I was working with kids with special needs in my background, I would see that sometimes. And
Mhm.
I saw a kid who his foot got stuck
Yep.
like that, actually. So it's an issue. I think some people are like, oh, whatever. Like, is it really that big a deal,
Overrated.
Dr. Pham?
Yeah. Yeah. It's a good question. And so toe walking by definition is walking on your toes a certain percentage of time. And every kid is different. Some kids walk on their toes 100% of the time. They've always walked on their toes ever since they started walking.
Mm.
Some kids, it's maybe 50%. Some kids, it's 20%. Some kids, it's only when they're excited or when they're nervous about something. So it really depends. But toe walking is walking with a toe pattern.
Right.
Typically, in children, a heel strike develops by about 18 months of age. There's a big study from one of the Shriners hospitals, and they looked at typical development of gait in typically developing children. And that heel strike initial foot contact, which is how the foot hits the floor, typically develops by 18 months. So if a child is walking on their toes beyond 18 months, yeah, sometimes we can do some conservative things. Sometimes we can watch and see if it's getting better, if it's a low percentage of time. But oftentimes we want to look at why and we want to treat it early because the earlier we treat it, the easier it is to treat and the more successful we can be. Because again, the child, if they're two, hasn't had as much time learning that toe pattern compared to a child who's 10, right? The child who's 10 has maybe had 9 years of practicing toe and it's much more challenging to treat. And I will say, if you go out to the airport or the mall and you sit down and you look around, you will see people in the world who walk on their toes. And that's okay, right? Toe walking isn't necessarily going to kill you. Can it be harmful to your body? In some ways, yes. And those ways are the calf muscles can get tight. Sometimes we see the structure of the foot changing. Some kids, as they get taller and heavier,
Mm.
they have foot pain. They're limited in their endurance. When kids get old enough, sometimes we can't do conservative things to get that flexibility back in the ankles. Sometimes it requires surgery, which, if we address it early, we can oftentimes prevent, which is wonderful.
Yeah, exactly. I think that kid I was referencing earlier did have to get surgery. And of course, we want to avoid that if possible. And now I see when I started with the fitness program as well, I had no idea how common calf tightness is. And
Yeah.
it's mind blowing. It's like extraordinarily common. And this just exacerbates it, right? This makes it worse. And now there's a cascading effect, which I'm sure you could spell out, like
Yeah.
knockdown consequences from toe walking. Cause now if it's like being in high heels, right? So we're talking about walking around with your heels elevated up off the floor.
Yeah.
Right? So now there's this tension there. So of course, that will affect your balance, right? Because you have a much smaller base of support that you're walking on, right? So your balance is going to be off. Now, if your calves are tight, and then of course we have stereotypes about how the hamstrings will get tight, right? So calves and hamstrings, I've known so many people, they're extra tight, and then it's like, "Okay, let's try working on our squats." And then, of course, the squat pattern
Right.
becomes like, "Oh, this is a hot mess," but it's no matter how good the demo is, or I'm like, "Oh, this is how we do it," or "This is where, right, your butt's gonna go down, gonna use your hips here, you're gonna keep your head at the top, you're gonna make sure there's a big checklist of things that you're looking for, like, do the knees knock together in the middle when you drop down and do a squat? One of the other things is, can you keep your heels on the floor? And that will give you some more power as well. But the
Yeah.
squat, first and foremost, this is one of those, is it not one of those developmental milestones that we all need to reach as a basic movement pattern? The squat's not just a strength training. It's not just like for pumping iron like Arnold, like, that's why I do my squats, but we're talking about a very normal,
Yeah.
fundamental, and important kinda move.
Yeah. Yeah. It's not technically one of the developmental milestones, squatting, but what it does is it allows you to build the strength through what we call your hip girdle, which are basically your glute muscles, your quad muscles, your hamstrings, so that you can then stand and walk. And what prepares you for that, when you think about it developmentally, baby is crawling, then baby pulls to stand. And then before baby can walk, baby's going to go up and down. First, they might just like plop down to the ground because they can't control that down because it requires strength to lower your body down. But once they get better at that, they're gonna go up and down, right? They're gonna get something off the couch, they're gonna get down, and they're gonna crawl over to what they're doing next, and then they're gonna pull themselves up, and then they're gonna go down, right? And all of that up and down movement, those are baby squats, and that helps build the strength through the hip girdle to then start doing things like cruising and then walking from there.
Oh, interesting. So I guess that's why I thought it was one of those fundamental milestones, like a caveman who would squat down around like a campfire or something like that, and then they hear something rustling in the woods, and then they stand back up, and then they're like, "Oh,
Uh-huh.
okay, false alarm," and they squat back down. So it seemed like a natural kinda move.
It is an important life skill, and let me tell you, since I work with, young adults and adults who have, childhood disabilities, that is the biggest thing that people want to be able to do, is to
Mm.
get up off of the floor, and it's hard. It's hard when your body is physically bigger and when you have some of the tightness in muscles that we see happening over time, but it's an incredibly important life skill to be able to get up.
Okay, right. So to wrap this up now, we see the issue here, and I know that you do this toe walking clinic. So this is something you focus on and you're helping people with this issue. So are there maybe like 2 or 3 things that we could do even on our own at home to handle toe walking and the accompanying tightness you get in the calf muscles?
Yeah. I think honestly, the big thing is identifying it early and addressing it early more than anything. Because you can say, oh, do PT, do some stretching. Depending on the child, saying, go home and do 2 minutes of stretching for your calf muscles, 5 minutes of stretching twice a day for your calf. It doesn't matter.
Not
Um,
enough?
it's not enough. It's not
Okay.
a yeah, and it doesn't retrain the pattern of movement, so
Mhm.
sometimes we use shoe inserts, sometimes we use full ankle braces to help keep the heel down, because you can say to a child, "Get your heels down, get your heels down, get your heels down, get your heels down," until the cows come home, and the moment you step away, the moment they go to school and don't have someone there saying, "Get your heels down, get your heels down," they're gonna go back up on their toes.
Right. Right.
And you're gonna drive everyone crazy, parents and children included.
I see.
So, I think my biggest piece of advice would be to not wait and see, and once you're at that, like, 18 months to 2-year mark, like, think about it and do something about it. Get an evaluation, start the process, to see if there's something more that you should be doing, because then we will be more successful. For kids who are older, there's still a lot that we can do. It just looks a little bit different.
Yeah, that's the last thing that I had in mind there. What if you're a teenager and you're going through adolescence, you got all these growth
Yeah.
spurts, you're like shooting up
Yes.
like a weed, but now you've got these tight muscles.
Yeah.
So maybe they do need a diagnosis or need an evaluation, I should say.
Yeah.
Should they is it not gonna help at all? Like, don't bother stretching at home, or is it still gonna be an important part of the lifestyle where you're working on it, but maybe you do need a little extra help? What if you're a teenager instead of a really little kid?
Yeah. So for the teenagers, because of those growth spurts, because they've been walking on their toes for a longer period of time, they tend to be tighter. And especially in those situations, the daily stretching is just not very successful. And nobody remembers to do it, which is okay, myself included, right? I don't remember to do my PT exercises. I am the first to admit it to
Mm,
patients and families, right? And I think there are things that we can do to help either with a prolonged stretch. Sometimes we just need to get that flexibility back with something like serial casting or with surgery, and then see if we can maintain flexibility. Sometimes we decide, hey, let's go really hard into retraining walking using something like AFOs and
mm,
see if we can be successful in that. Sometimes we
mhm.
use these for somewhere on the order of 6 to 12 months. Some adolescents say, "No, I'm not wearing those during the day. What else can we do?"
Yeah, I could see that. Yeah,
Yeah,
so these are
exactly.
like ankle orthotics that some
Yeah,
people may not wanna wear to
yeah,
school or something like that. Yeah,
exactly.
I believe that.
And so in those cases, there are things that we can do at night, right? Sometimes we use bracing at night just to help maintain
Yeah.
flexibility and just allow you to maybe walk on your toes during the day. Some adolescents get to the point where they decide, I want to stop doing this, right?
Mm,
And if they have the flexibility, they themselves will decide, I'm going to stop going up on my toes. Sometimes we need to help them get the flexibility to be able to do that. But many of them are really not interested anymore in using the daytime braces.
mm.
And so sometimes we use bracing at nighttime. And this is the stretching that is helpful. Wearing a brace on your ankles for 8 hours, 10 hours. That is the amount of stretching that is helpful, not
Wow.
the 2-minute stretch twice a day.
That's incredible, though. I see, I'm glad you mentioned that, though. That had not occurred to me that you could wear that overnight. But it's funny, it reminds me of some kids when you go to the orthodontist, you have
Yeah,
to wear, like, night guards or braces and things like that, and they could yes,
exactly.
sometimes you just put them on overnight, so you get a big accumulation of time because 'cause
Yep.
you're trying to make a big course correction, so we're talking about this can reset or help increase the flexibility for your ankle and stretch out the calf so that you regain your range of motion and can walk a little more normal. Fantastic. Okay. So, speaking of equipment,
Yes.
okay, adaptive equipment like these orthotics, or you tell me, we've got a big need here for adaptive fitness equipment. There's people all over this area. So I want to talk about the equipment that people need and then the issues that we have. It's very expensive to buy, but then you may grow out of it, or it may not be exactly the right fit. So you need to swap it. And so we were talking about the potential for an adaptive fitness equipment library. So please take it away.
Yeah. When we think about equipment, there are lots of different types of equipment that children and young adults may benefit from. Some of that is equipment to help them walk. Some of that is for safe bathing, safe positioning for things like feeding or using their hands. Some of that is fitness equipment like a sports wheelchair, which is a bit different from your typical wheelchair that you would think about. And so lots and lots of equipment is covered by insurance. Some of it is not. And it depends on the insurance company. Sometimes they will pay for some of it. Sometimes they will pay for all of it. Sometimes they will pay for none of it. And as you mentioned, when children are young, especially and they're growing a lot, sometimes we have different needs for different types of equipment that change rapidly over time as they're growing. And so there exists equipment closets. They are loan closets. They're all nonprofit organizations. And what they do is they loan out equipment to families to use for their child for a period of time. When they're done with it, they give it back. They fix it up and clean it up and loan it out to the next person who might be able to use it. Families will donate equipment to loan closets that can be used for other children. And we have no loan closet in the metro Washington, D.C. area. The two closest
What?
loan closets, I know, right? There's one in Columbia, Maryland, and there's one in Richmond, Virginia. Those are the two closest loan closets that we have. And so, what we're trying to do is to build energy, build a following, build a group of people who are interested in helping to support one of these existing organizations to come to the metro Washington, D.C. area to support our community of children and young adults who have equipment needs. And from a fitness standpoint, the big one that I get asked about a lot is an adaptive tricycle, which is something that, hands down, I have never seen a single insurance company pay for. They're quite expensive. And so that's a piece of equipment, for example, that a lot of families are looking for. Or a lot of families will often look for, if a child has a wheelchair, they might look for an adaptive stroller that maybe is a little bit lighter for certain situations. Insurance will only pay for one of them, they won't pay for both. So, what we usually do is we ask insurance to pay for the wheelchair because it's the more expensive one. And so, things like adaptive strollers are pretty common that families are looking for those as well.
Interesting. It's really unbelievable that the loan closets exist, but we don't have one.
Yes.
Absurd.
Yeah,
So
it
I
is.
think, yeah, we should do something about that. And
Mhm.
I imagine we'll take a bit of fundraising, which is something that we were talking about, but maybe we'll do a special live action fitness fundraiser. That's what I have in mind, where you could get some money together, try to build this loan closet. And especially in an area where there's so many people in the DMV area, the need must be enormous, and it would save people a ton of money.
Yeah.
Is that is right? It has to.
Yeah, and beyond that, there are a lot of families who really just will not buy the equipment that maybe their child would benefit from, because it's a huge expense. Medical equipment
Mm.
is incredibly expensive. Once you call something durable medical equipment, they jack up the price and make it incredibly expensive. And so a lot of families just can't afford to get the equipment that their child would benefit from. So it's not even saving people money. Some people may be able to pay out of pocket to buy equipment, but there are some people who just can't. And so their kids go without that equipment.
Yeah, well, exactly. That's what I had in mind. Or even if you have the equipment, maybe your kid outgrows it. And then you're like, well, now what? Right? Well, replace it by a new one. Or what are you going to do with the old one? Right? You could return that to the loan closet and then allow someone else to use it. Right? Like reduce, reuse, recycle. You remember that
Yeah,
old campaign? It's like we don't need to reinvent the wheel. So somebody else has this
right,
tricycle, maybe they've outgrown it. Somebody else could use that same thing and it would really help make a big difference in their lives. I think if they had that equipment, they'd be able to get moving, they'd be physically active, they could spend time with their friends. We're talking about being able to go ride bikes outside or go to the park, the playground, maybe playing sports, who knows what it is, but that overall, not just for your physical fitness, but you're able to get out and connect with friends and have a social life. You just need some adaptive equipment to allow that to happen, to enable you.
right.
All right. So that was fantastic. Thank you so much, Dr. Pham. Appreciate all the information. And for anyone who is interested in contacting you, how do they get in touch?
Yep. So you can reach out to our office. Our phone number is 571-310-2502, or you can visit our website at www.reachpeds.rehab.com. And thank you so much for having me, Jason. I appreciate it.
Absolutely. Perfect. Take care.
You too.